All right, well, good afternoon, everyone. Thank you again for spending some time on a beautiful Friday to hear a little bit about essential forensic concepts for clinicians. So, my name is Joyce Stankowski. I have worked for the state of Ohio for about 23 years, and a lot of that has been in forensic mental health. And when I say forensic mental health, this really means mental health these days because, for a number of different reasons, the way a lot of our patients are coming to clinical attention is through the legal system. It's sad, but sometimes when people in the community don't have good access to care, one of the ways they get clinical attention is maybe they get arrested for something like trespassing. And now suddenly people are recognizing there's something mental health wise going on. So it's not great that a lot of folks are getting mental health care through the criminal justice system, but that's a little bit of the world we're living in. So I think it's really important that you clinicians have some understanding of some of the ideas involved in forensic mental health. And this helps not only the people you're seeing, but it helps all of us avoid any kind of liability or confusion. So, I have no disclosures. And my outline is to describe a few foundational concepts in forensic mental health, discuss how these concepts are used in decision making in mental health, and then apply some ethical principles and documentation standards. And if anyone has questions, please put them in the chat. I'm also going to give my email address. Be happy to discuss any questions now or later. So I wanted to start off by telling you all about a woman I recently saw. My job is I work for the state, but I also work for Cuyahoga County, and I interview inmates who are in jail pre-trial, and the defense attorney has realized it doesn't seem like they know what they're doing maybe, and we need a mental health evaluation. So I saw a woman who was at one of the local libraries. There's a lot of students there, the new school year. It's a college library. People have backpacks, people have computers, and a lot of items started to go missing. So students, somewhat surprisingly, would maybe take a break and leave their backpack lying on the desk or leave a couple of items in the conference room and walk away, probably thinking, hey, this is a library, this is my school, what's going to happen? Well, what happened is they were robbed. It turns out a lot of backpacks and wallets and purses were disappearing. So the campus police started to look into this and try to figure out what was going on. And they were a little stumped. There weren't cameras in the library. There was a camera at the entrance, but that was it. But then one day, a student alerted employees that there was a woman sitting in one of the conference rooms, and she was surrounded by ID cards. So she had an array of bags in front of her, and she had different people's driver's licenses, pizza reward cards, ID badges, credit cards, and she had them all spread out on a table. She was sorting through them like she was about to play some kind of card game. And campus police came in, and she had a lot of items that did not belong to her, so they arrested her. So I saw this woman, I'll call her Jenna, and my job was to try to see her and figure out a couple of questions. So a little bit about Jenna, 28 years old, and they charged her with a lot of counts of theft. For every single identity card she had that wasn't hers, it was a different count of theft. So she was facing a bunch of felony charges. And a little bit about her background: she did not have a place to live, she didn't have a job, she didn't really have community treatment, and she did have a history of substance use and psychosis. And when I say that, I say the substance use, she clearly had a history of using meth, cocaine, a bunch of stuff, PCP. The psychosis was a little bit unclear because she would go to an ED, she would talk about hallucinations, bizarre delusions, but she'd also have a positive tox screen for meth. So it was unclear in some of the reports I saw, was this from intoxication or was she really psychotic? Well, in jail, she became very withdrawn, but she would do bizarre things. Sometimes she would sit in the cell and she would take off her clothes and then put them back on backwards. She started to refuse not only any kind of intake, but medication and food. And the question in the jail was, does she have the capacity to consent to any kind of treatment? We're worried about her and we're not really sure she knows what's going on. And I'll mention the one question that always crops up in a correctional setting is this person potentially exaggerating some symptoms just to avoid talking to the guards or avoid criminal responsibility? So often the correctional officers wonder, hey, is Jenna really ill or is she faking it? The other question was, the attorney went to see her and she's sitting there with her shirt on backwards and the attorney's saying, hey, Jenna, do you understand your charges? And she's looking at the wall and not talking to him. So the attorney's saying to the judge, I don't know if this woman is competent to stand trial. So this is where I got involved to try to figure out what the heck is going on with Jenna. So I'll talk more about Jenna later on, but a little bit about forensic mental health. What is it? Broadly speaking, anytime you hear the term forensic X, it means law and X. So forensic pathology is pathology as relates to legal questions. Forensic mental health is any kind of mental health where clinicians are using their clinical expertise to help attorneys, courts, etc. And in the case of mental health, it's clinicians are applying their expertise to legal questions around treatment, competency, and things that a psychiatrist or psychologist or mental health clinician might get confronted with. Even if people aren't specifically practicing with courts or in a correctional setting, understanding some of this is important to everyone because, as I mentioned, it's everywhere in mental health. The more you know, the better care you give, and the more you will reduce any kind of liability. So, what types of legal questions are there? Well, legal questions in mental health can broadly be defined by the type of court that's involved. And the picture on the left is probate court. The picture on the right is criminal court. Probate court, the purpose of probate court is to help. Essentially, help out people, help out their property. If people or citizens get their rights limited through probate court, it's for the overall good. And the concept behind this is a Latin term called parens patriae. And that basically means the state is acting as a parent because a clinician out there has said and presented evidence, this person really can't take care of themselves. And the state has to step in and act as their parent or guardian. So a common example of this is if somebody does need a guardian, whether it's a limited guardian of their finances or medical condition, or a complete guardian for absolutely everything, the point of a guardian is somebody is determined that even though this person is an adult over 18, and therefore we in society say they should be able to do anything they want to do within reason and the law. They are unable to make decisions, so the state will step in. Every psychiatrist, whether or not they specialize in forensics, will interact with the probate court regarding involuntary hospitalization and involuntary medication. And the probate court manages these things because, again, if we are talking to the court about trying to hospitalize someone or treat someone who doesn't understand they need that treatment, we're not trying to be punitive or run that person's life. We as clinicians are trying to say this person is sick, and part of their illness is they don't recognize they're sick, and therefore somebody needs to step in. So, dear judge, we need your help legally to say the state's going to step in and take care of this person despite their objection. Testamentary capacity is something that occurs a lot. This is basically your ability to make a will. And you can imagine as people live longer and have more conditions that might affect their mental status, like dementia, and they write wills, and those wills are contested, this is actually quite a large area that's usually more forensic than general psychiatry. Because probate court has this goal of helping, the amount of evidence the judge needs to make a determination is not beyond a reasonable doubt. It's not close to 100%. You are taking away somebody's rights if you're involuntarily hospitalizing them, but you're doing it for their own good. So you want to have, as a judge, enough evidence to feel good about that. It shouldn't be just 51%, right? It should be a little bit stronger because you are taking away this person's liberty. But you're not talking about throwing them in prison, so it doesn't have to be beyond a reasonable doubt. So the standard for the judge in considering the amount of evidence needed to make a decision is usually thought to be in the middle, maybe 75%. You need to be more certain than 51, but not 100. Criminal court, in contrast, and this is where forensic psychiatry traditionally steps in more versus probate, which any psychiatrist has an interaction. Criminal court, first of all, it's divided into misdemeanor courts, which are municipal courts, or felony courts, which are common pleas. And felonies are more serious, so those courts tend to hear more serious charges and cases. The point of criminal court is to preserve the justice system, not really to act as a parent or help out. They are trying to make sure that our laws work, our justice system works. And when they limit somebody's rights, they do it to basically punish or deter. So when you are a judge in a criminal court, your standard of hearing evidence is close to that 100% beyond a reasonable doubt, because you are going to take away somebody's liberty, but it's not to help them, as in involuntary commitment, it's to punish them. So you want to be very sure that you're doing this fairly. So how do clinicians get involved in this? Well, that judge wants to be very sure he or she is being fair, and it would not be fair to have somebody stand trial on a serious charge or any charge if they didn't really know what was going on, if they weren't competent to do that. It also would not be fair to throw somebody in prison and punish them for an act if at the time of that act, they didn't know what they were doing. So this is where clinicians come in and they give the court an opinion. They provide a clinical opinion to the judge that helps that judge make a legal determination. Now, as a clinician, if I'm coming up with an opinion, I don't have to worry about the judge's standard. I only have to look at the evidence in front of me, Jenna, for example, and try to make a determination with a reasonable degree of certainty whether or not I think that she is really ill and not competent, or whether she is able to move forward. But my standard is probably a lower bar, more that 51%. I don't have to be super sure. I just have to think it's more likely than not and give that information to the judge. And the judge takes that information and uses it to make his or her decision. We often shortcut as clinicians a discussion, and I might say, I saw Jenna and I didn't think she was competent to stand trial. But that's wrong. Clinicians do not make any kind of legal decision. And if you declare somebody, if somebody has been declared incompetent, that is by a court. Because if somebody's not competent, if they're not competent, if they have a guardian, etc., that's a judge taking away or limiting somebody's rights. That's not a clinician. So when clinicians say, hey, I'm going to evaluate this person for competency, or I thought they were competent, we don't really think that. We give an opinion about whether or not they can understand and assist, but the judge is the one who makes the determination. So just to highlight that, really what we're talking about as clinicians is, does somebody have capacity to make a decision? Does Jenna, for example, have the ability to understand, hey, Jenna, you're kind of sick, you're acting weird, you've had a history of hallucinations, let's try some treatment. Does she have that ability? That's what I would talk to Jenna about and give that clinical opinion to the judge. Then the judge, based on that, might say, well, according to the doctor, Jenna doesn't seem to have the ability to make her own decision about medication. Therefore, I'm going to say we are able to administer it over her objection because she's too sick to understand what's going on. And the reason this process is in place is because once we all turn 18 in the United States, we are presumed legally competent to marry, to vote, to own property, to make a will, et cetera, unless and until a court finds otherwise. So really then, if we're talking about a foundational concept and a really common clinical question that we clinicians assist the court with, it really boils down to capacity. So capacity is something that it's a foundational concept because it's not limited to forensic medicine. It's in all medicine, really all clinical situations. When you are interacting with a patient and you're discussing any kind of decision with them, it's really important to know, does that person have the ability to understand what you're talking about and use those facts to make some kind of rational decision? And decisions, it's not just a rational decision. All decisions, you need to have the facts, you need to be able to use those facts, and you need to have the ability to do it without duress. And the most common situations these come up in is in probate court, treatment questions, and in criminal court, competency to stand trial questions. So I'm going to show a slide that I love because I love chocolate. I eat chocolate every day, so guilty pleasure. So, and actually this is, I don't know if you can tell, this is a picture of chocolates that are designed to mimic body parts. And this is a real thing. Somebody once gave me a gift of this after I gave this presentation, and the chocolates really do look like a heart or a lung or a hand. They look very stunning, but I was so disappointed they tasted like wax. So yeah. So anyway, it's best to have the slide and get my chocolate somewhere else. But this might seem like a silly example, but we make these kind of decisions all the time. If this box of chocolates were sitting in the administrative hallway where I work, and the boss had just brought them in from her vacation, and she was excited to have me try one, I would have to look at this and say, okay, so what's going on here? Chocolate, I like chocolate. What are the benefits, risks, alternatives? Well, the benefits are I like chocolate. I'm going to feel good if I eat one of these dark chocolate ears. The risks, more calories, not awesome, little sugar rush, not a big risk. Now, if I was diabetic, that would be a different calculation. What are the alternatives? Well, I can walk away. Or if I'm going to eat any chocolate, maybe I'll eat one piece and not four. Is it my choice? Well, if my boss is kind of hovering over my shoulder and saying, hey, Joy, try one, try one. I just brought these back special. I know you love chocolate. Even if I don't really want it, I might feel a little bit obligated to try it. Now, maybe I could say to my boss, I'm not really hungry. I don't really want it right now. But what if my boss was saying, you have to eat one of these chocolates or I'm going to force you to do some kind of extra lectures or research or something like that? Well, now it's not really my choice. So the point is, any decision an adult makes, we have to be able to understand the different factors involved, and we have to be able to make a decision without somebody leading us or guiding us or coercing us. Now, an important thing about decisions are you really need to talk to the individual because on the face of it, some decisions look really bad. This woman is standing, she's got her toes in the water. There's a big sign saying shark sighted today. I'm not a shark expert. I don't know how shallow the water is before sharks are nibbling on your toes, but I wouldn't do what she's doing. However, what if we talk to her and we say, what are you doing? You just walked by the sign. And she says, well, look, I know I'm a shark expert and I know that the kind of sharks they're sighted are only in deep water. And it's not going to bother me if I'm just standing in a little bit of water. Okay, well, what seemed irrational actually is pretty rational since she is a shark expert. Now, if somebody else was standing there and they had no clue and they were at risk, maybe you'd be more worried about their rational ability to make a decision. This is a little bit of an old picture, and I apologize to those who are vegetarians or vegans in the audience, but it's pretty interesting. This is Lady Gaga before she became super famous, and she's wearing an outfit made of meat. So her hat, if that's what you call it, is a steak, and her dress, I mean, it's pretty gross if you look closely at it. She showed up at a publicity event wearing this outfit, and she got a lot of publicity. And Lady Gaga is now worth, I don't know, a $500 million or something, and has had a very robust career. So for her, perhaps wearing a dress made of meat in public was a rational decision. If I showed up at work next week wearing this, I probably would get publicity as well. I don't think it would help my career. And therefore, for me, it would not really be that rational. And people would be right to take me aside and say, are you okay? So again, we can't make a snap decision about somebody's ability to make a rational decision. We need to talk to that person and try to hear where they're coming from and what their thoughts are. So I mentioned informed consent is the most common capacity question that comes up in general medical practice. And it's usually, interestingly, triggered by a treatment refusal. So even though we physicians, if we're going to give information to somebody about a possible treatment, we want them to make their choice. We don't want to be sort of coercive or suggest one thing or another. I know it's hard, and I've seen myself in the hospital, and I'm sure a lot of people on this line have seen, if somebody has had a heart attack and we think that it's obvious that they should now undergo a cardiac catheterization and they refuse, we're going to be disturbed by that and question that decision. However, just because we think that's what they should do, that person could have a rational reason for refusing that treatment that we need to respect. Maybe it's a religious reason. Who knows? There could be different reasons. So it's important really to consider that person's decision-making ability, whether or not we agree with their decision. So interestingly, many people who are in a hospital, depends on the study you look at, 25 to 40% of people in a hospital have a problem making a decision. And it's usually because they have some kind of psychosis, whether that's from schizophrenia, or if they're in the ICU, if they've been in the hospital forever, they could have ICU-related psychosis. Depression is very common in the general population. If you're sick enough that you're in the hospital, it's going to be even more common. And if you're depressed, you might lose some of your motivation and effort to really listen, especially if you have a serious condition and the doctor's trying to talk to you about a scary procedure. You're feeling depressed, maybe you don't have the motivation to listen to them. And then delirium can be very common. You're talking about people in a hospital who are on different medication, who have different sleep-wake cycles. So figuring out if somebody has the capacity to make a good decision is a very common question in medicine overall. So what is giving somebody appropriate informed consent? What does that mean? Well, that means that as a clinician, you have to tell that patient what their condition is, what the risks and benefits of treatment are, and what the risks and benefits of no treatment are. And I put a little insert from an aspirin package because I remember even now when I became an intern, the very first medication I had to order as a new doctor was aspirin. And even though aspirin is over the counter, when you are ordering a medication in the hospital, it has to be done by a doctor. Well, I had a lot of stress and anxiety about this because you go through medical school and you hear, well, aspirin is a blood thinner. What if this person has an undetected condition where they can't coagulate well and this one aspirin is going to push them over the edge and they'll bleed to death? What if they have an undetected allergy? And it's all on my head if I'm now giving this person an aspirin. So I went and I talked to the patient and I was trying to ask, have you ever had a bleeding disorder that you know of? Have you ever had an allergic reaction to any kind of medication? And this poor patient just said, look, I have a headache. I take aspirin all the time at home. Just give me an aspirin. And I thought, you know what? This is reasonable. This person is just asking for some reasonable information. And what I needed to tell that person is, well, you know, you're familiar with aspirin. Probably the biggest side effect is it might hurt your stomach a little bit. You haven't been eating a lot. You might want to take this aspirin with some juice. And you don't want to take a ton of this aspirin because it could thin your blood and you're already getting some things looked at. That was the amount of information that was good for this person. So the court has actually called this a reasonable person standard. Nobody expected me to sit and go through every last possibility with this patient about aspirin. It should go without saying, but sometimes docs are sloppy. You should discuss this and document that you've discussed it before you give out that aspirin. Because at the end of the day, patients do have the right to decide, and they do have the right to refuse treatment. So the common law, British common law, from whom we've taken our legal system, has long said you can't touch somebody without their permission. It's called a battery in common law, and here in our modern legal system, you could be charged with assault if you touch someone without their permission. Our Constitution, the Eighth Amendment, says people have the right against cruel and unusual punishment. So don't force me to take a medication I don't want. The 14th Amendment says people have the right to due process, meaning they have the right to hear all the information. And if they're going to make a decision and somebody's going to disagree, they have the right to have their day in court. This has been upheld by the Supreme Court. Justice Cardozo, for example, said every human being of adult years and sound mind has a right to determine what shall be done with his own body. So if we clinicians are going to ask the court for treatment over objection, we really should have some good evidence. And here in Ohio, that evidence primarily comes from a court case that was Southern Ohio in 2000. And this, by the way, is how forensic psychiatrists, psychologists sort of cut their teeth on the legal system. You hear about a lot of cases from Supreme Courts that are considered landmarks. And they're considered landmarks because all subsequent courts look to that case to make future decisions. So Steele versus Hamilton County is a landmark case in Ohio because 25 years later, it is what we still use as the standard of care. And the upshot of this case was that Mr. Steele was a young guy who was hospitalized because he was having weird thoughts. He was fighting people only he could see, but he wasn't really dangerous. And at the time, the thought was, if we're going to go ahead and medicate somebody over their objection, it has to be they're imminently going to hurt someone or hurt themselves. We've got to rush in there and emergently try to maybe give them a shot. Well, Mr. Steele wasn't doing that, but Mr. Steele also didn't seem to know that he needed treatment, and he was in the hospital for months and months, and he wasn't really moving forward or making any progress. So the Ohio Supreme Court considered this case and said, well, do we really need for Mr. Steele to be so sick that we've got to run after him to urgently prevent him from hurting himself and maybe give him an injection? Or can we maybe say, hey, Mr. Steele doesn't seem to have the capacity to make a good decision here, so maybe we can do this more thoughtfully. And the Ohio Supreme Court said, you know what? We think that the standard is not really dangerousness, but it's this whole idea of capacity, because we are going to go back to this idea of the probate court and the parens patriae being a parent if the person lacks the ability to parent themselves. So if the person lacks the ability to understand that medication is in their best interest and nothing else is going to help them get well enough to be discharged, then the probate court can say, yes, it's okay for the hospital or wherever, it's usually a hospital, to give this treatment over that person's objection. So that's the current standard in Ohio. It's a capacity evaluation. There is another case, this is now federal, that theoretically could be used to ask a court for medication over objection. This is a forensic case. So Mr. Sell was a dentist who had a lot of charges of Medicare, Medicaid fraud. And he was locked up in federal prison because the US federal system was not happy with this fraud of Medicare, Medicaid, alleged fraud, I should say. And Mr. Sell was locked up, but he was kind of quietly psychotic and delusional, apparently. He wasn't really dangerous. He wasn't really doing anything. But the point of locking him up was for him to get treatment to no longer be delusional so he could have his day in court and the government could say, hey, look, did you really defraud Medicare, Medicaid? But nothing was moving forward because he was just hanging out being quietly psychotic. So the question came before the US Supreme Court, well, are we going to violate his right to due process? And due process is really usually what happens in that probate court situation where the court has to make a decision by clear and convincing evidence. And this is Mr. Sell, and he's not before probate court. This is criminal court. So are we going to violate his rights if the criminal court decides that he can be involuntarily medicated for the purposes of him being competent to stand trial? Well, the US Supreme Court said, no, we're not violating his rights if the criminal court tries to do this, but here's what has to happen. The treatment has to be appropriate, and it has to be necessary, and important government interests must be at stake. Well, I can tell you that as a forensic psychiatrist, I'm about to go to my annual meeting coming up in October. I don't think many jurisdictions have used this particular test to order medication over objection because there's a lot of subjectivity there. Mainly, what does important government interest mean? And the US Supreme Court didn't really clarify it, unfortunately. So I can say that as a clinician, if I am ever familiar with needing to request medication over objection, I go back to this idea of capacity because I can wrap my mind around that. I can understand if a patient can't make a decision because of their mental illness. I'm not really sure how to make a decision about important government interests. So I'll mention the flip side is that, by the way, patients have the right to treatment as well. You can't just keep somebody in a hospital, for example, take away their liberty and just watch them sit there. And unfortunately, this used to happen in the past, which is why those of you who have ever heard of Joint Commission or a hospital survey and patient rights in the hospital, it all happened because of an Alabama case in the 70s where basically there was a huge state hospital, patients were kind of hanging out, and there was one nurse for maybe 3,000 patients. They weren't getting a lot of treatment. This 15-year-old kid was locked up. He wasn't getting any treatment. And at some point, what happened was Alabama changed its cigarette tax. The employees didn't get a raise, and the employees of this state hospital kind of encouraged the patients apparently to file a class action lawsuit saying there aren't enough workers here. Interesting how these things come about. So the US Supreme Court said, you know what? You are right. Patients in a hospital have the right to have sufficient qualified staff and by the way, also visits, a humane environment, no unnecessary medication. You got to prove it. And if they don't need to be there, discharge them. It's quid pro quo. If you're going to take away their liberty, you have to make it worth their while. So, how does a clinician evaluate if somebody can give informed consent? Well, really, it boils down to this clinical interview. You know, what you're doing as a clinician is you're giving information, assessing somebody's capacity. You can do that just by talking to them, but there are these tools out there, and this MacArthur group have a lot of different tools for assessing capacity. So they even have one for treatment. And basically, this is a tool where it helps a clinician by prompting the clinician. Did you tell them about their condition? Did you tell them about their treatment? And do they seem to understand? It's basically what a clinician does anyway, talking to a person. But if you need a little bit of extra help, there is this tool. Now, switching gears a little bit to talk about forensic work, and the most common question that comes up in criminal court, competence to stand trial. This is the most common criminal capacity question, and ECHO had a lecture on this a month or so ago, so I won't get into the weeds too much. But I mentioned that the way the court makes landmark decisions is usually through a case that makes it all the way up to the Supreme Court. And that's true of this. Dusky versus United States was a US Supreme Court decision that has set the standard for understanding and evaluating competence to stand trial. Mr. Dusky was this 33-year-old guy hanging out with teenagers. He was probably developmentally delayed, looking back on it. And even though these teenagers seemed to be more involved than him, he was the adult. And at the end of the day, they kidnapped a girl, drove her over state lines. There was a concern for attempted rape. And as the adult, he had a ton of charges. Now, it was clear that he had a history of schizophrenia. So somebody evaluated him and said, well, you know, he's oriented. He knows his name. He knows he's in jail. And he kind of remembered getting in the car and driving. So we think he's competent. So he went to trial and got quite a large sentence. His lawyers appealed and said, wait a second, he really didn't understand. Yeah, he knows his name and he sort of remembered the day, but this was not fair to him. And the US Supreme Court said, you know what, this is right. The question is not just, can you say your name and sort of remember what's going on? That's not capacity. Capacity is, does Mr. Dusky understand what's going on? And can he make a decision with his attorney? And the US Supreme Court was more wordy about it, but basically they said the real test is capacity, not just being oriented. So, how do you evaluate competence to stand trial? It's another capacity evaluation, but it's specific to trial situations. It's a forensic interview because the purpose of this interview is to answer this question, not to provide any kind of treatment. There are, because this is forensic, a lot more guidelines and tools out there. A clinician assessing somebody's forensic capacity, or in this case, ability to understand and assist an attorney with trial, you want to kind of make sure you yourself understand these components so you can ask them of the person you're evaluating. There's something called the McGarry criteria that I see used a lot. And basically, it breaks down a lot of questions for the clinician to see if the person understands. So if I were an attorney, I wouldn't need this help. But since I'm not an attorney, I need a little bit of help knowing what to ask the person, including, well, what are you charged with? Do you know what charges are more serious, felonies or misdemeanors? Do you know what the role of the judge is? And I myself have to understand all that before I can understand if they understand. And then I need to sort of assess, do they seem to be able to assist? They can probably assist their attorney if they can talk to me for a couple of hours and be rational about it. But I might ask them a little bit, well, have you and your attorney talked about what you might do? And if they say something that seems to be rational, that's good. If they say something that seems to be off the wall, that's a red flag. There are a lot of tools that are more structured to help clinicians with this, including if there are folks who have things like developmental disability, there's a special tool to help with that. Children, juveniles, there's a special tool. What happens if somebody is evaluated and found to be not competent but needs restoration? Well, just a little bit about how this affects the whole system. As I mentioned before, this is the most common forensic question. A lot of evaluations are done in the jails because basically people aren't getting the treatment they need in the community. So they're coming to jail very sick. And therefore, the question that tends to come up is, are they competent? If they're not, they're remanded usually to the state hospital for restoration. And under Ohio law, depending on the severity of the charge, people can be locked up for restoration treatment for up to a year. So the difficulty with this is you got a lot of beds in the state hospitals that used to be used for people from emergency rooms that are now being used for forensic competency restoration. It's possible maybe to send somebody outpatient for treatment, but you have to be pretty stable to be able to be outpatient. There's been talk of just restoring people in the jail, which basically means make sure they're getting the treatment they need in the jail. But not every jail has the funds and the staff for that. So right now, this is creating a bit of a mess in our system. And if you ever hear that the state hospitals are full of forensic patients, this is why. So, oh, another point, if somebody is not able to understand this criminal court stuff by the end of their time, usually a year, then there's no legal ability to hold them anymore. So they're either discharged to the community, or more likely what happens is if somebody's sick enough that after a year they still don't have capacity to be able to understand what a judge does, it's not a high bar. They probably meet criteria for not being able to take care of themselves in the community at all. So we go to probate court. We're now leaving criminal court, going to probate court. And the usual process in probate court is people get their due process to have a full court hearing, and the doc files an affidavit with court for this. But there are sometimes emergency situations, by the way, which is in Ohio called our pink slip, where we skip over this due process temporarily because somebody's thought to be imminently dangerous. And this pink slip allows, it's kind of like giving somebody an emergency shot of medication. If it's an emergency situation, we'll take away somebody's liberty temporarily. And in the case of this hold of a pink slip, for a few days, but it doesn't mean that we can hold them indefinitely. At some point, they're either discharged or voluntarily hospitalized, or we have to go back to this whole full due process. So what I'm trying to emphasize, I guess, is people have different rights that we have to uphold as clinicians, even as we're trying to help them. So a little bit about other capacities. Insanity or sanity at the time of the act is basically somebody's capacity to know if they were doing something wrong at the time. It's what their mental status was like at the time they did their alleged act. So if you think about Jenna, if I was talking to her about collecting all these ID cards at the library, really what I'm trying to get at is not how she's looking today. What was she thinking when she took the backpacks? And the test of this has changed over time. It used to be thought that somebody could be thought to be insane and not criminally responsible if they were as mad as a wild beast. Then the test was thought to be no, if they've got a delusion. Then the test was thought to be they can't control their emotions. But the test that's most common, it arose out of this case in Britain in 1843. Mr. McNaughton was kind of paranoid. He thought he was being persecuted. He tried to assassinate the head of the police, Sir Robert Peel, who, by the way, if you're familiar with the term Bobby for police officer in Britain, this came from Sir Robert Bobby Peel. Anyway, he tried to kill Peel. He shot his secretary instead. He was so delusional that basically the prosecution withdrew the case. He was found insane. Queen Victoria was kind of annoyed at this point. This was the second or third assassination attempt on her or her people by citizens who didn't seem to understand what they were doing. So she said to her judges, you guys have to come up with some kind of standard. And they did. And that standard was basically what we are using to this time today in Ohio. Ohio Revised Code says somebody is not guilty by reason of insanity if they can prove that at the time of the act, they did not know as a result of severe mental disease or defect, they were doing something wrong. So they have to prove it, which means it's an affirmative defense. They're affirming they did the act. They're now going to prove that they had a good reason for it. It's pretty rare, And it's all about their mental status at that time. So if we go back to Jenna, I saw her, the first question was, did she understand that she's acting pretty bizarre? By the time I saw her, she's still acting bizarre and she's been in jail a month. So whatever she was using before she came in, I didn't think that was the cause anymore. Did she understand she had something wrong and might need help? She really didn't. Did she understand she was in jail with charges? She really didn't. So I wrote my opinion about this. The court ended up finding her not competent, and she got sent to the hospital for restoration. I don't know if she'll be restored or not. If she is and she decides to plead insanity, the question will be, hey, Jenna, at the time you took all these ID cards, what were you thinking? Did you know it was wrong? I don't know the answer to that, but I would guess that Jenna really didn't think she was doing something wrong because she didn't try to hide it. When campus police found her, she's hanging out in a conference room with all of her stolen goods. That's not something a thief would usually do if they were really trying to evade detection. A little bit about evaluating capacities. Documentation is really critical, and it's critical because what you document reflects on you. If you do a crappy report or a crappy note and it's sloppy and you've got spelling errors, your credibility is going to look a little bit like the guy on the left. And who would you rather represent you, the person on the left or the person on the right? So, for those of you who are movie fans, I just saw this old movie recently, Dangerous Liaisons. Another reason documentation is critical. In this movie, Glenn Close's character writes a lot of letters. Guess what? When you write something down, it lives forever and it could be public. So you better be very careful what you're writing. Be neutral, be professional. And if you are not, there was an interesting study that looked at bias and said that if you have bias in your documentation, not only does it reflect on you, it could impact wrongly. Your bias could impact future clinicians and care. So you've got to be careful. So a little bit about this role when you're evaluating somebody for the court versus for treatment. You really have to be clear with that person. And if you are answering a question for the probate court, like guardianship, the probate court's job is to try to help. So it's more okay if you're also a treater. Is this person disabled or not? If, however, you're doing it for criminal court, then you really shouldn't wear those two hats of relationship and now trying to make a neutral decision. And when in doubt, there are a lot of ethics guidelines for all of our disciplines. So in summary, it's important to understand how the law interacts with what we do and do good capacity assessments. And when you make an assessment, have clear boundaries and clear documentation. So that is the end. Thank you all so much. And if there are any questions, I'm happy to answer in the few minutes we have left.